Get ready to listen, learn, and earn CE hours. This podcast features content from an accredited CE activity provided by Calibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits.
All right, welcome back to our series on navigating delegation. To continue this discussion, we have Dr. James Stowe with us. In episode 1, Jay walked us through why we need to understand the importance of proper delegation and the repercussions of improper delegation. So through this episode, we're going to understand the scope of practice and really hit on the what it looks like to effectively delegate and what those differences are between the roles of LPNs and CNA. All right, Dr. Stowe, can you help us understand the legal and ethical obligations that are associated with each role, the LPN, the RN, the CNA?
Absolutely. When considering the legal obligations, they really are essentially the same. And I think the legal obligations are really the impactful for RN and LPN. CNA, yes, there is, but not quite to the extent. Obviously, they're not doing the extent of work with a patient. They're not doing the invasive actions that the other two would. But legally, the obligation is when you've accepted that patient and are responsible for their care, you have a duty to provide care and do it correctly. And really that duty is what actions would, and if you're RN, what reasonable RN in the same situation, what would they do? LPN would be the same. You can always ask yourself, what would a reasonable person in my same education licensure in this situation do? And so for Alabama, it's where I am. There are roughly 60,000 nurses, about 40,000 practicing, 45,000 practicing. So there's a pretty good sample of what for example, a med-surg RN would do. And so as long as you adhere to those duties and adhere to that practice, you're fine. If you breach that duty, many times you're still okay. But if you breach that duty and that breach, which is breaking what you should do, and that break causes a harm, then you could be in trouble. Okay, you could be legally in trouble. Ethically, obligations, ethically, not only do you have the ethical responsibility to follow the laws, but ethically you have the responsibility to follow the policies and procedures of the hospital. But more importantly, I would argue that you have the ethical responsibility of providing patient-centered care because that's our job, right? That's our fundamental belief and the fundamental reason that we have entered into healthcare. It may be because you need to pay the light bill, but truthfully, you can pay the light bill in a lot of places, but you wanted to do something other than that, or you typically wouldn't be there. And so ethically, that's a responsibility to do good and help the patient.
Right.
But that is a bit more challenging, ethically. There's not really a ethical policy. There's not really a guidepost for you or a guideline that says do these things and you'll be ethically okay. It's really more of a personal guidepost. So there's a lot of questions and a lot of leeway there. And that's what makes the practice of law and practice of medicine fun.
That's true. It's a lot of gray in both areas. But where there shouldn't be gray is in our communication when we delegate, especially who we're delegating it to, what we're trying to delegate. So can you help us to understand that the collaborative communication that needs to happen when we're delegating?
So really and truly, the most important thing in my opinion with delegation is clear communication. Now that clear communication takes a number of different forms. It's not simply me as an RN telling the LPN, hey, I need X, Y, and Z. It's not simply that. It is way more involved. Okay? Clear communication is, does the hospital have clear policy communicating what each level of care or each licensure can do? I would challenge you, go ask your hospital. Go ask them, what are the specific roles that a nurse, an LPN, and a CNA can do? If you get a response or a policy that dictates that, I would be very, very shocked. They simply don't have that. There's legal repercussions for doing that. So that clear piece of communication is most often missing.
And in education, we didn't teach that. When you came in through orientation, that wasn't anything that we taught, now that I think about it.
Oh, we don't teach it. There's when you're in school, when you're in nursing school, you come in there and speaking only for a 4-year degree, a bachelor's degree, they go in and they tell you, oh, you're going to have help. You're going to have people that will do certain things. Okay. And they will do that. No one defined they, and no one defined what task they were going to do. You just had this belief because you were being told that, hey, I'm going to get help when I get out. And that's not
And you
always
saw
the case.
it in clinicals, like we said
You
in
see it.
episode 1. You see it when you're in clinicals.
You see it, but what happens when you're now a nurse and you have your off orientation and the tech's all called out and there's no LPNs on your unit? You're it, tag. And now what? Who do you rely on? You train a certain way and then all of a sudden they're out. So it's a very difficult thing. We look for more clear communication from, say, the state, from other entities that can guide us. And I will tell you that the state, speaking of Alabama, the state of nursing, looking up, they don't have a list of, you absolutely have, RN has to do this, RN can't do this, LPN has to do this, LPN can't do this. And same for CNA. CNA is not even regulated, so they don't even mention them. So when you look at that from RN to LPN, one of the big things is, okay, what can you delegate, right? Surely the regulating body is going to espouse that. And they don't, but you have to go in there and read certain things, certain decisions on other cases, certain appeals, certain rulings that they've had, and you can rule some things, and they'll come out with things that say, for example, there was one that said, you can't delegate anything that has nursing judgment involved. That makes sense. I can't delegate to a CNA something that a nursing has to assess and judge what to do. You can't delegate invasive or sterile procedures. Okay, LPN may not have been trained on those, so that makes sense.
But then you have places where if an LPN gets further training, then they can do it. And I think one of those for the state of Alabama, correct me if I'm wrong, was IVs.
It is, and it's interesting. In this specific rule, just to backtrack just a second, they stated that finger sticks and peripheral venous phlebotomy, while invasive, that's allowed. You can delegate that.
So you can't do an invasive procedure, but
we will allow these things.
Yeah.
And you have to hunt and peck. It's not under a nice little tab, what you can and can't do. And so, yeah, it's just really convoluted. And then you add in, like you mentioned, these extraneous certifications after the fact. Well, okay, so you've got that. How is that communicated?
Right. So how do I know when? So for me, my background is ICU. So you don't really have a lot of tech in ICU, first of all. You definitely didn't have LPNs in the ICU. And so for you, if I was pulled out to a med-surg unit, I really wouldn't know what all a CNA could do or an LPN could do unless somebody told me on that floor. Because where I am, I'm responsible for even bathing the patient. I mean, yes, the tech would come in and help, but because of all the lines you had, the ventilator, you needed to be in there to ensure that the patient was okay if they were critical. So that I wouldn't know where to start other than the known things like glucose and vital signs, because that's really all they did for us. Besides even our baths, sometimes 2 nurses would go, even if we had a tech, it'd be the 2 nurses going in there to get baths in the ICU.
We started this with clear communication, and I think that's where we will start and where we will probably end is clear communication. I have no problem, and I don't know why we're reticent as kind of lumping myself into nursing leadership with posting what you can and can't do. I mean, it's in the break room. You get nurses floated to you from all over. If the skills differentiate between LPNs, why isn't that listed somewhere?
Yeah. Or maybe even like something, oh, they love badge buddies. Oh, you're
Uh,
an RN? Whoa, okay, what else is on it? There's so many things on a badge these days.
yep.
Well, tell me that they can do IVs.
It's if you look at some of the studies, and this is cross board, and this is by no means scientific, but some that I have read have said, but you got to tell somebody something 8 times before it really sinks in, before they learn it. So you get a nurse that floats from an ICU to the floor. Does she have time to listen to what can and can't be done, or who has what scope of practice 8 times before she even gets her shift started? Because let's be honest, you report to your unit, you get there, and then you find out you float, and then you got to get to the new unit, you got to put your stuff up, then you got to go get a report. You're an hour behind, right? You're an hour behind the 8 ball, and you don't know that unit, and you're not happy to be there because you're not comfortable. It's not somewhere where you go every day.
It's not that we're unhappy to be there. It's we're uncomfortable. We are out of our comfort zone.
You're unhappy because you're uncomfortable because, again, and I take that as a good thing. A lot of people call it an attitude problem. I call it a positive reaction, because if you're uncomfortable, you have the desire to keep the patient at the center of care, and you know that for that unit that you don't know all the ins and outs like you do your home unit, and there's a fear that that patient is going to lose the care that they need to get. And so I'm not upset by that, by a nurse leader. What I need to do is have the responsibility, and somebody do, we need to educate you on what you can, what you can't do, what is expected. I need to give you, and one of the things I have done in the past is create a little pamphlet, something, and I had them specifically designed where they would fit in the pockets of my scrubs. I'm a guy, I like the scrubs with the pockets on the pants, okay? So we made it that wide, but it was a fold over, what have you, and you could flip it and say, this is what we do, when we do it, how we do it, yada, yada, yada. Almost like a cheat sheet for when you come out with a new EMR, new computer system, you have how do I enter an order? Let me flip to page 3. How do I delete this? And so while it doesn't have all the answers, it gives you something that floating nurse gives you something that you can hold on to, you can grasp to, and you can go back to. It adds a comfort level, because the sooner you become more comfortable, the sooner you can calm down and think about what the patient needs and simply react and provide it, because you know how to take care of them. It's just a different environment.
Right. So we know that the scope of practice for LPNs and CNAs varies from state to state. Can you kind of help us walk through the different tasks that LPN versus a CNA that RNs can, at the end of the day, though, if an RN delegates, the RN is still responsible for that task legally, correct?
Correct. And now we get into some really interesting gray area when you take a step back and you look at it. So I think we all know that the RN is responsible for initial assessments and the more complex procedures, drawing blood. Patient's got a PICC line. I can draw blood out of the PICC line, right? I can assist with ventilation, a ventilator, triple lumens, Foley catheters, art lines. There's all these things that I have been trained and checked off to do that are a little more high functioning. LPN is not. Their really scope is vital signs, assessment, education. They can administer some medications, but there's limitations. They can't administer paralytics, for example. And why is it? It's not a negative. It's that they haven't been taught what are the side effects. What do you do? What do you look for? When are the right situations, the right times to do that? So it's really a protective thing. So they have a limited scope. And then the CNAs are really, we mentioned them earlier, and they're kind of a pretty big step down on the capabilities, assisting with eating, bathing, brushing teeth, nail care, those type of things that are very important. Personal hygiene is unbelievably important in infection control. And also positive self-image. I mean, you'd be surprised how far that takes a patient. But when you think about scope and you look for kind of some guidance and some help in helping you kind of chart that course. I looked up on the Alabama State Board of Nursing's website and specifically typed in delegation and all this kind of good stuff. And they have put on there a Alabama Board of Nursing released, and I copied it and said, Alabama Board of Nursing scope of procedure -RN/LPN decision-making model. Oh, great. That's wonderful. And the LPN and RN presumptively they're talking about what delegating task. They're at the bedside. And this is an 11-step process before you get to you can do the task, perform task.
So is that for the RN to use to determine if they can delegate?
Both. RN
Okay.
to delegate and LPN to accept the delegation. And it talks about what does the board say? What does the Nurse Practice Act say? But it does go into what is the education and capabilities of the delegee, the LPN in this case. What can they do? Well, how many RNs know what the LPNs have studied in school? What courses have they undergone? What was their orientation like? It's two different paths typically in orientation for some. You kind of have that commonality where everybody does,
Yeah.
and then it kind of breaks off. LPNs go here, nurses go here, CNAs take a different path. There's at different parts of the week. They start breaking off earlier or later.
Yeah.
Who shares with each individual? Who shares with the nurses what the LPNs are checked off to do? Who shares with the nurses the education that the LPNs have undergone and from the different schools to know when they get to the floor, hey, I can delegate X, Y, and Z because they went to ABC school. We don't do that. That's part of the state's decision-making model. And at the very end of it, it says, even despite all of these actions, the last question says, are you prepared to accept the consequences of your actions?
I don't know. I'm not sure.
Well, I mean, talk about striking some fear. And I know that's a precautionary question designed to make you think. But if I'm already sitting on the fence and I don't know, I'm now completely scared and I'm not doing anything.
I'm not delegating anything. I'm going to try to do all of it by myself because I worked really hard for my license.
Yeah, and if I'm the LPN, I'm not accepting it because I don't remember what was in school because I was working 3 jobs, taking care of a family, just trying to make it through to get this position, to get licensed. And I made it through, and while I knew it, I haven't practiced it. So nothing gets delegated. And now what happens to the patient? There's no patient-centered care at this point, right?
Yeah.
When it comes to this task. So we talk about clear communication, and I circle back to it. It's absent. That clear communication is absent, and I think we have to do a better job of, while I know a tremendous amount of work went into this, and we want to consider all of these steps, we want to consider all this stuff, it's just not clear and concise. So we've got to go back to the drawing board and come up with a methodology, a step-by-step, a much easier way to say, you can do this, you can't do that. And if you've got an exception where you can do something like an IV certification, hey, your badge is a different color. Your pen is different. Oh, that's on there. You have a ribbon on there. We announce it every day, yada, 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 whoever you're assigned to. Hey, by the way, you know that Sally Joe here has IV certification. This team B, your LPN does not. RNs have to do it. We have to have more and better, clearer communication, delineation of duties, or else we're going to freeze. We're going to paralyze ourselves, or we're going to have the worst thing, and that is creep, where we just assume people can do things, and their scope of practice starts creeping into the nursing practice, and we have bad outcomes. And so at the end of the day, if we don't have a clear communication, those patient-centered approaches and patient-centered positive outcomes are going to be.
If you were a travel nurse today, what advice would you give to a travel nurse when it comes to effective delegation, safe delegation for their license?
It's difficult. It's difficult because the first thing I would tell you as a travel nurse, both as a just conscientious travel nurse, just as a conscientious nurse wanting to do the right thing, but also legally, is I would ask for the hospital you're going to, your new works, policies and procedures governing delegation. What is allowed, what isn't allowed. Now, when they're not able to give that to you, then what? Right? What's the second step? Contact risk management department, contact the CNO, her office, and see. Okay, and have something put down, put in writing. What can they do? What can't they do? What you're going to get is potentially down to the nurse director, manager, or maybe even a team lead in that area, and they can say, you can ask them, hey, what do LPNs do here? Write it down, email it to risk management, say, hey, this has been checked off, or this is what I'm told LPNs to do. I need to confirm this before I delegate it. The hospital may not love that, right? Because you're putting them on the spot. To be honest, you're getting it
in writing, black and white.
You're making them make a decision, but it's your license. Okay, it is your license, and you have the choice to either comply, right, with whatever they tell you, or have some backup and say that that's okay. And then when they give you the 4 things that can delegate, stick to those 4 things. Don't creep. Don't say, hey, look, I'm going to be out of here in 3 months. I'll roll the dice on this. Don't do that. Because remember, it's patient-centered care. At the end of the day, if we allow individuals that haven't been properly trained to do things, we're not thinking of the patient first.
So one of the things about delegation is that whoever does something should document it. So if I delegate something appropriately, then I should not be the one that documents that it was done, other than maybe to say, so-and-so did this, if you were in the room and you saw it happen. But what is the legal repercussions for choosing to document something you delegate as you did it, but you delegated it?
So this is an interesting question because, we have this belief if it wasn't documented, it wasn't done.
Right.
That's really not true. That's not true under the eyes of the law. It's just really hard to prove that you did something if you didn't document it. I mean, let's just be honest. If it's 3 years later and you're now in court, how do you prove that you remember specifically what you did at this specific time and specifically should have written?
Right.
It's kind of a hard thing to buy, right? Kind of reasonable. So you really need to document those things. So you have this area where if you're going to delegate something, so let's say you've got a critical value, lab calls with a critical lab value, right? LPN takes a call. They tell you it's a critical enough value to change cardiac rhythm, right? So I might even, as the RN, go in and document, notified of the critical lab value, what it is, and say LPN instructed to call physician for verbal order. I'm not telling her to treat it because it's probably going to be something that they can't hang. It's an IV, it's medication, it's probably outside their scope. But I'm doing something that I can at least get the order. LPN needs to go and say, hey, called Dr. Smith. She gave me an order for X, Y, and Z at this rate, yada, 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 writes it all down. Okay, great. You communicate with the nurse goes, gets it, hangs it. If there is a delay in the LPN calling and getting an order, I now have a partial leg to stand on saying, hey, I recognize the issue. I delegated to try to address the issue, right? Hospital allows me to delegate this task. Hospital allowed this. That patient didn't do it timely. Bad outcome happened. Get on to the person that didn't do it timely, not me. So this is not about placing blame, but it is about appropriately documenting step by step what did happen. And the LPN, when they called, they should put in there, hey, received a note, yada, yada. They got that order or they did that task. They need to document that. Nurse also needs to come behind them and document their note. Received this order, did yada, 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 X, Y, Z, okay? Don't think that it's done just because the LPN's documentation is there that may not be sufficient. Okay. They may have the knowledge or report the finding, but you better actually address the issue.
Right.
And that will get people a lot of times, as they don't actually address the issue that they're reporting.
And I will put a disclaimer on your example. First, I'm going to say it's an example, but second is make sure that an LPN that you're working with can actually take orders, because I have worked in areas where they were not allowed to take orders. Only RNs were allowed to take orders. So
absolutely. Again, look at your state laws, what you can and can't do, and then also what your hospital will allow them to do.
Right.
Okay?
Yes.
So there's two different levels there. So, yeah, check.
And it is hard. I've worked in a federal hospital over in Japan, and I've worked in a lot of different state hospitals. And so I have seen firsthand the difference in trying to remember who can do what, where, when, and why. But at the end of the day, I'm responsible for the care of that patient. And so I can't assume that somebody is going to go take vital signs, that somebody is going to go take the glucose check on the patient. I can't assume that this is going to happen. I need to make sure that it happens. And
as an RN, when you talk about that, it brings up something, we talk about clear communication and almost over communicating. As an RN, if you don't set your practice up to have that LPN tell you every time they get a value, whether it's a blood sugar, whether it's a vital sign, whatever it is, to tell you, even if it's 100% normal, you're going to have skips. You're going to have misses, because I want to know real time, each and everything.
To set up that routine and that partnership between you of laying out what your expectations are and what their expectations are of you from the CNA and from the LPN, so that you know how to work well together. And for me, I a lot of times will go in and check documentation, because, if you get a glucose and it's electronic, a lot of times it will roll over and you can see it in real time, checking that. But just making sure that everything is done that is supposed to be done for that patient at the end of the day, regardless of if you delegate it or not, it's our responsibility as the registered nurse. So it does make delegation for me difficult, because it's sometimes easier to just do it yourself.
If you are OCD, control freak, it's very difficult. It is very difficult. You do give up some responsibility there. I think, I think team nursing with different tasks, different things that can be delegated, can be very successful on the floor. It can be somewhat successful on a telemetry unit. But if you get much more critical than that, I think there's challenges. It's from my own personal experiences. The education level, as far as what you're looking for, what you should report, what you should act on immediately, becomes much more impactful when you're in a much more acute area than when you're in med-surg. Okay. Med-surg, when I have floated before, like I've had an understanding with my CNAs where I knew the hospital policy, anything less than 60 on a blood sugar was considered critical. That was just how the hospital defined it there. So my comments to them were, if it's less than 60, I need you to write down, what it was, and I need you to go to the previous one that was taken, find the date and time it was taken and what the value was, and then come tell me directly. Well, for me, the CNA was like, I don't understand that. You're making me do more work. But for me now, I have a trend, right? I can kind of see which direction we're going. Has it stayed low or we're trending down? What's going on? But that helped me be able to react instantly as to what I needed to do with that patient. And once I was able to explain that, communicate, the CNAs were now empowered to go and look, and they would go back 2 or 3 and say, Jay, I mean, it's all over the place. Not really trending in one direction. What do you think it could be? When your CNA is evaluating those things from a tech level, a nursing assistant level, and trying to have a medical conversation with you, it's phenomenal. That means they're receptive to all these other things. So clear communication, but I would agree that the higher acuity areas you have, the more difficult it is to rely on someone else, especially their assessments, because it's just that much more critical, that education experience that you have that they don't, and it really shows for. So I'm a big proponent for team nursing. I'm a big proponent for LPNs,
Yeah.
but I would steer clear of them in the ICUs. Arguably some progressive care areas, I would steer clear of them. Step downs, we'd have to have some real clear defined roles there. But your med surg units, I think a lot of beneficial care, a lot more up in our med surg.
And I know you were saying steer clear, and I think that what you mean by that is to you need more of the critical thinking that is taught to a registered nurse to ensure that the care of the patient, that the patient is receiving the care that they need to have in order to have a good outcome.
Agreed. When you look at that, there's a reason that the ratio is 2-to-1 in most ICUs, maybe 3-to-1, depending on acuity.
Yeah.
There's a reason. It's not for anything other than if we keep the patient at the center of care, they need the frequency of eyes on, and that is assessment. They need the frequency of that skilled assessment, which the LPN, while very skilled, doesn't have the education or the assessment skills to the level of the RN. No fault of their own. That's the education path that they have.
Right.
So where can we properly place that level of skill that would work best for the patient? So, but that's really, and you hit the nail on the head of the coffin there. If you, the ICU, that's the reason that there's
Right.
it's really the frequency of assessment that needs to occur by that skilled personnel.
Yes, there's a lot of titrating in there for medications, and absolutely. We are running out of time for this series, but I really loved what you said about empowerment. So the art of delegation has that underlying piece of effective communication, but also the empowerment piece of that. And so as we wrap this up and we come to the end of it, what can you just kind of, for those who are going to be walking away from this and going to the hospital to work, how can they roll that empowerment into effective communication well?
I would challenge you next shift you work, next couple of shifts, or one, think about it. Observe what your LPNs and specifically CNAs are doing and have conversations with them. When's the last time you told somebody, hey, this surgical procedure happens, I look for these things? Have you told them the signs and symptoms you look for? They're going to be in the rooms. Why can't they help you assess? Why can't they help look for those things? Now, you still have to go do your assessment. You still have to go do things. But if you're not planning on being in that patient's room for another 2 hours because you're doing something and they see dilated pupil, they see one that's dilated, they see, hey, this patient no longer can move his right foot and his leg. Wow. And they come and tell you. So I think if you empower your members of your team, imagine how quickly and how much better service and care we can provide to our patients. You'd be surprised. We oftentimes think of limitations like, oh, nurses have so much on them, or this person has so much on them. That's the very person that I put in charge, right? Give them some authority and give them the ability to do more, and they will rise to the occasion. I think you'd be very surprised, your LPNs and your CNAs. They deal with some pretty rough situations, right? They care for some pretty difficult patients. They want to be there. They want to help. Empower them. Let them help. Let them do more, see more, and be more eyes and ears for you. You're always going to have that responsibility to go in there. You're always going to have that responsibility to go and oversee patient care. But hey, if you've got some people that you can train to see more and do more and help you take care of that patient better, you'll find that your workload becomes a whole lot easier, and it will actually benefit you. And that really is the definition of team nursing that we kind of started with. And that was here 50 years ago. That's the team nursing that existed where everybody worked collaboratively for the patient. And that's what we've strayed away from it, right? And we've got to relearn that collaboration in order to have it successful today.
Absolutely. This has been very insightful. And this is such a gray area. And I know even as we come to the end of this, it's still probably pretty gray, but I hope that we've been able to give you some more places to go to find the answers, who to talk to find the answers, and most importantly, to protect yourself and your license. So thank you so much for joining us today, Jay. You always bring so much insight to the discussion. So I always love having you join us for these. To our listeners, I hope that you have gained insight into this topic, into how to more effectively delegate and to safely delegate. And we encourage you to explore many of the other courses that we have available on elitelearning.com to help you grow in your careers and to earn CEs.
This podcast featured content from an accredited CE activity provided by Calibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits. Take your learning to the next level by subscribing to more podcasts on compelling healthcare topics.